Japsam. I serve as the course director and facilitator for this series. We have several ECHO series, and this one is tailored for the outpatient and community setting. However, you may find the topics may be relevant for older adults in other settings as well. And so we're really glad that you're joining. Next slide. So about ECHO, this is a forum for mutual teaching and learning from experts from each of us on the front lines. And as the ECHO motto goes, everyone teach, everyone learn. And it'll take all of you to, put our brains together and create this community of learning. Next slide. A little bit about our format. After a short lecture from an expert, we will share expertise from the rest of the interdisciplinary team and then open up for a time of case discussions. So we invite you to share any geriatric cases, even if it may be on a topic not related to today's lecture. Our team is willing to share our collective wisdom with you. The only requirement is that we ask you to keep it HIPAA compliant. Next slide. As we have on the next slide, which basically says that, everything is confidential on this call, so no need to feel embarrassed about any questions. No question is too stupid or irrelevant, and we want to create a safe learning environment and, hopefully encouragement, this environment of encouragement as well. But everything must be HIPAA compliant. Also, just to remind you, these ECHO case consultations do not create or otherwise establish a provider-patient relationship between the ECHO specialist, the patients, or U.S. providers. So this is purely educational. Next slide. And if you never joined us before, this series is run on the second Wednesday of each month from 12 to 1 p.m. as a 1-hour session with continuing credits available for nurses, doctors, and social workers. And this is our calendar for the next few months. So you can see, you can take a look ahead, and plan to join us on the future sessions coming up. Next slide. So this is just some Zoom logistics. Hopefully everybody's familiar with Zoom at this point. So I'll just move real quickly on this. So you have a mouse that you can move to the bottom of the screen, and you can find the mute in the chat tools. Next slide. This is the chat tool icon that it looks like. And basically, if you take your mouse and click on it, you can enter your name, discipline, and organization so we can have a record of who attends our sessions. And of course, hit enter after you're done typing into the chat box. Next slide. And of course, there's this mute button and unmute button, and we ask you to mute your button when you're not speaking so that we don't hear extraneous noise, and you can and we want you to unmute it in order to speak. Next slide. And just a word about Cme Credits. In order to receive Cme, you have to first have registered before joining and then complete the evaluation. And during the talk at some point, we will be posting the link that you can just click on right away, and it'll take you to a website where you can complete the evaluation form. Next slide. So just a few introductions. We usually have a team here, and I'm not sure where they are right now, but Mary Gautam, she is currently retired from the Hawaii Department of Health with decades experience in public health nursing. And Sarah Tompkinson, a licensed social worker with over 40 years of experience in geriatrics, mental health, and long-term care. Chad Kawakami is on military leave right now, so he will be joining us when he returns, probably in October. Okay, so next slide, which is, I think, no more. Okay, and finally, I'd like to introduce you to our guest speaker. So today's topic is substance use disorder in older adults, and today's speaker is Dr. Kara Lum. Give you a few interesting tidbits about her. Upon graduation from high school, she obtained a degree in European languages and literature, French, with the honors thesis focusing on the hero in post-World War II French theater. And somehow she parlayed this French degree into successful completion of medical school at Japsam, and a general psychiatry residency. And during that residency, she participated in the American Association for Geriatric Psychiatry, Stepping Stones Fellowship, and then chose to pursue a career in geriatric psychiatry, which she has never regretted since then. She is currently employed at the VA here in Hawaii, and she's part of the Ethics Consultation Committee. She's also co-chair of the UH Geri Psych Journal Club, and she pastimes include clothing construction, serving at Cub Scouts, PAC 311, Secretary in Travel, and she now resides in Kailua with their supportive husband and their 9-year-old son and their dog, Barkley. That's anyway. So please welcome her. And just a statement about disclosure. She has disclosed that she does not have any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So thank you, Kara, for joining us, and take it away.
Hey, thank you for having me. And hopefully my dog Barkley will not be making an appearance today because we have all sorts of things going on outside. So hopefully he'll be quiet. We'll keep our fingers crossed. So today I'm going to speak about substance use disorders in older adults. So next slide, please. And I'm going to just jump right to it in the interest of time. So anyhow, epidemiology, between the 2005-2006 national surveys on drug use and health, nearly 11,000 subjects 50 years and older were surveyed, and it was found that approximately 60% used alcohol during the past year, as well as cocaine and marijuana. However, the results of the survey were basically that drug abuse or dependence was very low. Please keep in mind that this is DSM-4 time, so they still had drug abuse and dependence at that point. Alcohol was the highest and most abused drug at nearly 3%. So their conclusion was drug use is not prevalent. However, it was much more common in the middle-aged at that point, suggesting that prevalence may rise substantially in the 65 and older age group as the younger cohort ages. So currently, those who were 50 in 2005 are really on the verge of the 65-year-old, age. And in a more recently studies by the National Epidemiological Survey on Alcohol and Related Conditions in 2012 to 13, there was a 2.3% 12-month prevalence of alcohol use disorders and a 13.4% lifetime prevalence of alcohol use disorders. And so very similar. And the drug use disorders were at about 0.8% and 2% for lifetime drug use. Okay, next slide, please. So why is this important? So alcohol and drug use disorders in older adults are associated with widespread impairments in physical, sociological, social, and cognitive health. So heavy drinkers versus non-heavy drinkers, or people who never drank, are more likely to have serious medical problems, poor self-perceived health status, more visits to the doctor, more depressive symptoms, less satisfaction with their life, and sadly, smaller social networks. Okay, next slide, please. Okay, so the problem is partially that these problems are underdiagnosed. They're often missed by healthcare providers. And some of the reasons are beliefs by the healthcare providers that the elderly don't have substance abuse issues. Also that drinking and substance use is understandable given life circumstances, which I think is very sad. But, in light of the fact that many of them suffer through death with a spouse, major illness, or decline in functioning, I think a lot of times providers feel that it's maybe justified to be using drugs or alcohol to cope. Often their symptoms are mistaken for dementia, depression, or another health illness or a condition. Older adults are less likely to seek help and more likely to hide their use. And a lot of times their relatives won't bring it up either. Okay, next slide. So who should be on the lookout? So in a word, everybody. Everybody should be on the lookout, including primary care providers, mental health services and substance use disorder providers, geriatricians, geriatric nurses, and direct care workers who provide in-home support, including like home health aides or Meals on with a Meals on Wheels delivery guy. He actually has a pretty good idea of what's going on in people's homes, as well as peer cover specialists. So, and including informal caregivers and formal caregivers, also faith community providers and social services. Okay, next slide, please. So let's talk about alcohol use disorders. So I just want to say that again, I'm going to talk about alcohol use disorders. The DSM-5 did away with alcohol abuse and dependence. So they're now renamed alcohol use disorders. Okay, and next slide, please. So a few handy definitions. So a drink. Luckily for us, alcohol is kind of pre-measured for us in servings that you would get basically at a bar. So 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of distilled spirits. So these don't include, high proof or overproof alcohol, just in case you were wondering. So like, the super strong rum, you would need less than 1.5 ounces of the shot to do the same thing. Okay, and drinks have roughly the same amount of alcohol. So between all of these, roughly the same amount of alcohol. Okay, next slide, please. So changes as we age. So as we age, absorption, metabolism, and excretion of alcohol is largely unchanged, but not entirely. However, less alcohol is needed to have the same effect. So this is the opposite of tolerance. So could we go to the next slide, please? So this is a schematic. It's very primitive, I know, that I drew myself. So, excuse anything that's really awful. But so alcohol is distributed in body water, not in fat. So that's what this is trying to show. So body water includes muscle. And with aging, usually, but not always, muscle mass diminishes. So with the diminishment of muscle mass, there is a decrease in total body water and therefore a decrease in the amount of tissue in which the alcohol is distributed in. So alcohol that is the same amount is now distributed in a smaller volume, resulting in a higher concentration. So therefore, even if someone's drinking patterns remain the same, a drinker may have more problems with increased age due to this like problems with the metabolism. Okay, next slide, please. So also there are some changes in metabolism. There is a lower concentration of gastric alcohol dehydrogenase in the elderly. And so this slows down the elimination of alcohol from the body. So we won't digress here, sorry, in the interest of time. Let's go on, please. Okay, so some diagnostic problems. So often substance use disorders are underdetected and misdiagnosed as screening instruments and diagnostic criteria are geared towards younger people or people in a different phase of life than the elderly. So SAMHSA recommends that clinicians consider DSM criteria for substance use disorder may actually not be adequate in diagnosing older adults with alcohol problems. And they recommend the terms at risk and problem drinking. And at-risk drinkers are people whose alcohol use have not yet caused problems, but may bring about adverse consequences. And of course, there are the problem drinkers, which I think everybody knows what those are. Okay, and Please note that even if some people don't meet full diagnostic criteria, they still may need some treatment. Okay, next slide, please. So here is the new DSM criteria for alcohol use disorder. I'm not going to go over everything, but I just kind of wanted to show how our diagnostic criteria may fail to kind of adequately capture possibly elderly adults. So please note that 3 of the 9 on this page, we'll go over them, may be difficult for the elderly to meet, and that's just because of their phase of life. So again, alcohol use disorder is a problematic pattern in alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the following occurring within a 12-month period. So alcohol is taken in larger amounts or over a longer period than intended, persistent desire, unsuccessful efforts to cut down. There's a great deal of time spent in activities to obtain, use, or recover from alcohol. There's a craving or strong desire to use it. Here we go. So alcohol results in a failure to fulfill major obligations at work, school, or home. So for a lot of the elderly, you know, they're retired, they're not working anymore, they're not attending school, and it's possible that, you know, they may be widowed and there's no one at home. So again, it's very hard to not to basically fail in their role when their role has sort of been complete. And so continued alcohol use despite of having persistent or recurrent social or interpersonal problems. So again, you know, they might not go out as much. Again, they might be widowed. It's again hard to kind of meet this criteria if your social circle is diminished. And also they have important social, occupational, or recreational activities that are given up or reduced because of use. So if you're not working or going out much anyway, you know, it might again be hard to meet this criteria. So also recurrent use of alcohol in situations where it's hazardous and alcohol use is continued despite knowledge of physical or psychological problems that are caused or exacerbated by the alcohol. Okay, next slide, please. And this is the continuation of the criteria. So tolerance or withdrawal. So, and note that again, there's no more abuse or dependence. So you have mild, moderate, or severe. And so severe is actually 6 or more symptoms. So without tolerance or withdrawal, all the criteria we saw on the other page, if you took out those 3, you'd have to meet every single one of them in order to test positive for severe. So again, it's pretty, I mean, it is hard for sometimes for the elderly to meet these. Okay, next page, please. So SAMHSA recommends that older men consume no more than 1 drink per day or a maximum of 2 drinks on any occasion. And there are lower limits recommended for women. So it's 1 drink a day and basically only 1 drink per occasion. So sorry, ladies. All right, next slide, please. So abuse of prescription drugs. So I'm going to kind of go over a few of the most commonly abused prescription drugs. In the interest of time, I'm not going to cover illicit drugs or smoking. All right, and again, you know, we could use alcohol as a prototype to kind of talk about drug abuse. Actually, in the DSM criteria, the drug use disorders, whatever they are, cocaine or methamphetamine, are very, very similar to alcohol use disorder criteria. Okay, next slide, please. So this is a shallow overview of prescription drug use. And so I tried to pick out the most common for older adults, and we'll get to those later, but patients 65 and older use more prescribed and over-the-counter medications than any other age group. And prescription drug abuse is thought to be prevalent, but it's very hard to study. However, you know, as prescription drugs, including opioids, are prescribed, it makes access easier And aging makes the body more vulnerable to these drugs. And it's thought that the use or abuse of prescription drugs will increase in the future. And worth noting that concurrent use of alcohol and prescription drugs is especially dangerous. And there are many interactions between prescription drugs and alcohol, as well as prescription drugs with other prescription drugs. Okay, next slide, please. So opioids, I think probably everyone knows that we are in the midst of a national health crisis, and there's an epidemic of abuse of prescription and illicit opioids. And so of the prescribed opioids, some examples are morphine, hydrocodone, which is a part of Vicodin, oxycodone, which is part of Percocet, fentanyl, and methadone. So again, older adults are at increased risk for non-medical use due to the high prevalence of chronic pain, so they already have it. And deaths from prescription drugs are increasing in frequency, enough so that in 2016, the FDA issued a warning about serious risk, including death, of combining opioids with any CNS depressant. And that does, of course, include alcohol. All right, next slide, please. So benzodiazepines. So I'm sure most of us are familiar with these. So this includes Valium, Ativan, Xanax, and Klonopin. Also, I've seen them very commonly prescribed for elderly. So benzo use, it's been found for more than 4 months is not recommended. And we prefer shorter acting benzodiazepines if possible, as the long acting benzodiazepines are more likely to accumulate and cause sedation. And of course, this can increase falls. If they're still driving, it can increase motor vehicle accidents. It decreases your attention, memory, cognitive functioning, and motor coordination. So one of those things that can look like dementia, of course. All right, next slide, please. And sedative hypnotics. So some examples include Lunesta and Sonata, commonly prescribed for sleeping. Of note, benzos are in the class of sedative hypnotics, but we've already covered them. So, and of course, benzos are not only used for sleeping, but anyhow, so as we age, sleep architecture changes. So there's a decreased amount of time in deeper sleep. There are increased awakenings, and overall, people sleep less. In general, these change in patterns don't seem to bother healthy adults. Next slide, please. So of the sedatives, there are no studies that show benefits if they are prescribed for greater than 30 days, and tolerance and dependence develop rapidly. So recommendations for sedatives include only symptomatic prescriptions, and those be limited to 7 to 10 days. There is frequent monitoring and reevaluation if use goes on beyond 2 or 3 weeks. Use the smallest possible dose, and no more than a 30-day supply be given. Okay, next slide, please. So instead of giving medications, it's recommended that we teach sleep hygiene, which is a very hard sell, I admit, but we should try at the very least. So sleep hygiene includes regularizing bedtime. So this is going to sleep and waking up at the same time every day, including on the weekends, and restricting naps during the day, only using the bedroom for sex or sleep, avoiding alcohol and caffeine. So no caffeine, usually afternoon, reducing fluid and food intake in the evening, taking some medications in the morning. So for example, medications like Lasix, that's going to make you pee all night long, take it in the morning and it should be gone, hopefully, by the evening. Or medications that are stimulants, such as methylphenidate, don't give them in the evening. Limit your exercise before going to bed. Exercise raises your core body temperature, makes it harder to sleep. And substituting behavioral relaxation techniques for medications. All right, next slide, please. And so screening and assessment. Okay, next slide. So screening instruments, just a word of caution. Screening instruments are screening instruments. They are not meant to replace an adequate exam or interview. The point is you need to talk to your patients even if they screen negative, and especially if they screen positive. So again, a positive screening doesn't mean they're alcoholic or they're drug dependent. It just means that you need to do a more adequate or more detailed assessment. And so a negative screening doesn't mean that the person does not have an alcohol use disorder now or will not develop one in the future. So we need to continue to be vigilant. All right, next slide, please. So the three of the most commonly used instruments for alcohol are the cage, the SMASH-G, and the audit, which is recommended for ethnic minorities. So for substance abuse, you can also go through the DSM-3R. There's the SCID, the Structured Clinical Interview. And there's also the DIS and the DSM-4. And I think it's also very helpful to identify functional impairments. Often it'll show up as people not successfully managing their ADLs and IADLs. Okay, next slide, please. Okay, so the SMASH-G. I'm sorry, I think did I just skip the audit? Or did I skip a slide? No, I'm sorry. Okay, next slide, thank you, sorry. So the SMASH-G, that stands for the Short Michigan Alcoholism Screening Test, geriatric version, hence the G. So it's 2 or more yeses out of the 10 may indicate a problem. So you can read them yourself, but if you ever talk to people, do you underestimate how much you drink? After a few drinks, are you not hungry or do you skip meals? Does having a few drinks help decrease your shakiness or tremors? Does alcohol sometimes make it hard for you to remember parts of the day or the night? Do you need a drink to relax? Do you need a drink to take your mind off problems? Have you ever increased your drinking after experience a loss in your life? Has a doctor or nurse ever talked to you about how concerned they were about your drinking? Have you ever made rules to manage your drinking? And when you feel lonely, does drinking help? Okay, next slide. And the cage. Everybody, I think, knows the cage. If they don't, they should. It's the best known, I think, and most widely used for alcohol screening tool, and it's super short, which makes it very easy to use. So C in CAGE stands for cut down on drinking. Have you tried repeatedly without success? Are you annoyed by criticism about your drinking habits? Do you feel guilty about drinking? And eye opener is, do you need a drink in the morning to function, basically? So if you answer yes to any of these, it's possible hazardous drinking. Okay. Next slide, please. Okay. So also it's good to routinely screen for auditory visual problems and also ask patients to bring in all of their medications, including OTCs, vitamins, and herbs. So as we know, people take all sorts of strange things, including now CBD is very common. And actually a lot of medications, including cough syrups and things like that, include alcohol. So it's good to just know what's going on. Always get a good sleep history, and if needed or you feel suspicious, do a GDS for depression. And there's the CSD as well. Okay, next slide, please. So screen early and often is the recommendation. So every 60-year-old, this is SAMHSA, by the way, who's recommending this, every 60-year-old should be screened for alcohol and prescription drug use as a normal part of their physical examination, and rescreen if certain physical symptoms are present or if there are major life changes. So major life changes include bereavement, retirement, or relocation. Okay, and often you probably want to link the alcohol or drug questions to medical conditions, such as, I'm wondering if alcohol may be the reason your diabetes isn't responding as it should. And again, not only providers can screen, there's volunteers, there's Meals on Wheels drivers, there's senior staff, there's home health aides. It helps for everybody to be on the lookout. And as always, it's very helpful usually to get collateral information, although of course we should ask the person first. However, just to note, collaterals might be difficult to obtain due to the fact that people maybe experience bereavement, retirement, or relocation. So social circles are smaller, so it's harder to get collateral information. Okay, next screen, please. So treatment. Okay, so treatment strategies. So the good news is that the elderly are at least as likely to benefit from treatment as younger people. The SBIRT is kind of the new thought on how we should screen in primary care settings. So SBIRT is just an acronym for screening, and then brief intervention, and referral for treatment. And this alone may fix problems. If not, they're going to need referral for treatment. And the important thing about SBIRT is that universal screening is the key. So everybody needs to be screened, even if you think there's a low likelihood, because you never know. And, please just keep your interventions. It's not like on TV. They should be non-confrontational and supportive. I think that helps people engage more rather than being in their face about it. Okay, next slide, please. So approaches for alcohol. It's recommended that they have age-specific group treatment, and it focuses on coping with depression, loneliness, and loss. So again, all of the major life changes that people may be experiencing, rebuild their support network, and have the classes at a pace and content appropriate for older adults. Have staff members who are interested in working with older people, and hopefully link them to medical services and also other services for aging, including case management. Okay. So one of the modalities recommended is cognitive behavioral therapy, either in a group or in a individual setting. And CBT they recommend should focus on teaching skills to rebuild the support network and managing grief, loneliness, and depression. So again, we're going over the same kind of major life changes, as well as general problem solving. And other group-based therapies should recommended expose them to information, the same information at least twice, just to make sure it sinks in. Establishing clear goals and purposes, and possibly giving them an outline so they know what's happening. Review all materials, and no sessions greater than 55 minutes are recommended. So in general, for the elderly, they recommend shorter sessions, but more frequent if possible. Okay, next slide. And of course, they can get individual counseling as well. And there are medical and psychiatric approaches, including medications. And I'm not going to go over them here, but they do include acamprosate and disulfiram, as well as naltrexone. But just be wary, because drugs can cause toxic effects. So there's the disulfiram. And treat depression if it persists after the alcohol or the drugs stop. And also, if possible, help with smoking cessation. Often it's helpful to involve their significant others if they're still around, or their family members. And again, if they can get some kind of case management or community link services, that could also be helpful. Okay, next page, please. And that is it for my part. And I'm certainly open to any questions. And the next page is just some resources on the slides if anybody is interested, or you can always email me and I'd be happy to help. Okay, thank you.
Great. John, can you unshare the screen so we can see the gallery view? And we really like to open this up to all of you. And I'm sure you guys have lots of stories or questions or words of wisdom you can share from your experiences. So first, I'm just going to open up to Sarah, actually, because she's on our panel and she has been at the VA for a long time. And I'm sure she has seen a lot of this. Any comments from your perspective as a social worker?
Are you?
We can hear you. Or we did. Can you hear us? Sarah? Well, oh, okay. So you can hear us, but we don't know what the problem with the audio is for you. Okay. Yeah, I don't know. Maybe John, you could work with her to figure it out. Anybody else have any comments on cases you want to share?
Can you hear me now?
Oh, yes. Are you trying to say anything?
I don't know.
No, we can hear you now, Sarah.
Okay, I just unplugged myself.
Okay.
I'm taking this computer outside. Just hold on.
Okay.
Anyway, now we're better. So the question that I guess, Dr. Lum, that gets raised is, how often, have you seen that people are self-medicating or over-medicating, especially during the pandemic? Because you brought up, people are feeling lonely and depressed. So, I think one of some of the questions on them that you mentioned do ask, if you're feeling lonely, are you using alcohol as a way to
cope,
to help comfort you? I just wondered, are we all seeing, this is to the group, are we seeing more of this going on where people are not just medicating with alcohol, but with other substances?
Yeah, if you're seeing anything, please put it in the chat box. We want to hear from you guys. Anybody seeing increased use of alcohol or other substances during this pandemic? Oh, more uses of CBD oil. Dr. Lum, you want to comment on that?
Yes, CBD is extremely popular these days. I haven't seen really consistent efficacy, as most people should know, and I tell the patients this all the time. CBD is not regulated by the FDA, unlike unlike our drugs, basically. So to me, it's even questionable how much CBD people are really getting, when even though something is packaged as CBD oil, but it's certainly out there. Prior to the pandemic, they used to fly me, the VA used to fly me to Hilo, which encompasses Puna. It's part of the Hilo district. And they didn't bother with CBD. They just went straight for the marijuana. But I do agree that I think there is a lot more CBD oil or CBD lotion. There's all sorts of preparations of CBD being used. But whether or not that has to do with the pandemic versus I think it's kind of come into vogue and it's totally unregulated. So I think it's very easy to get. You can order it off Amazon or the internet. So yeah, I don't know whether it's because of the pandemic versus just because it's there, basically.
Yeah, so I think, people think maybe that, it must be safer. So let's give it to grandma. Let's give it to mom. It'll help her feel better. Is there any risk for addiction?
I don't think they've done adequate studies on CBD yet. In general, it doesn't look as dangerous as THC. Supposedly, it doesn't really have as much of the euphoric, effects that THC does. Whether or not that's true, I don't know, but that's what they say through studies. Also, CBD doesn't, the good news is CBD doesn't have the kind of psychosis inducing effects that THC does. But I think we're going to have to wait for a while to see what really happens with CBD.
Anybody else? We have Dr. Lum here. We got questions we should ask. I'm wondering, Mary, if Mary got him. I know you're on as well. I don't know if, when you were doing your home visits, how did this sneak up on you and you discovered these things without anybody, otherwise would have fell under the radar were it not for your home visit?
Yeah, well, my favorite story would be I got a referral once on a elderly lady who was falling a lot. And when I went to the home, it was she and her husband were living on the second floor of an apartment as a walk up. But anyway, I was really interested because right at the side of her lazy boy chair on the floor was this huge bottle of alcohol. I don't remember what kind it was, but like bourbon or something. And I asked her what was that, and she said it was her cough medicine. And then when I asked, how often does she drink it, she says, oh, whenever she feels she needs to, she takes a little sip, and that's about all I could get out of it. But prior to that, nobody knew that she had a cough medicine problem. So it was sometimes it's really good to be able to make the home visit, like those Meals on Wheels people. So I would always ask them if they drink or if they ever smoked or anything. But just being in the home and keeping your eyes open, looking around to see, like empty wine bottles piled up or those kind of things is very useful, because a lot of times they're not going to want to tell you that they do still drink. Yeah, that's my main thing. I always ask them if they drank, but sometimes they didn't tell the truth. Yeah. Another thing I do want to say though is even though we identified that they had a drinking problem, like these been alcoholics for years, I can't recall that we were ever really able to make them change their behavior until their health condition actually forced them. I was thinking of one guy that was a terrible alcoholic, and for a medical reason he ended up in the hospital, and then he had to dry out, and then they could see how demented he was, and he never went back home. But it wasn't an, otherwise he wouldn't give up his drinking. Yeah.
Yeah. So we have a story here from Dr. Lum. She has a 69-year-old who adamantly denies her alcohol usage, yet multiple ER visits for falls, intoxication, etc., with the UDS always positive for alcohol. She says she does not want help. What do I do? So, I mean, there's help, meaning, I guess, brief intervention, and there's another one, which is referral. So short of a referral, which it seems like she's not able to do, what would you do? Have people experience this? Kara, what would your approach be?
Yeah, so unfortunately, I think we all know, we've probably all faced people like this, and not just with alcoholism, even for people who won't treat their diabetes, for example. Unfortunately, you have the right to kind of do whatever you want with your body, but up to a certain point. I mean, it sounds like this woman's health is failing. The question is, does she have capacity is what it's going to come down to. If she still has healthcare decision-making capacity, there's nothing, honestly, that we can do to force her. I think that there have been studies that show that healthcare providers talking to people, you'd be surprised, I guess, what people don't realize, but talking with her and telling her the dangers of alcohol use and maybe linking it up to how it's negatively impacting her health, all these falls and other problems. I don't know if she got in car accidents. I don't know if she fights with her husband. I don't even know if she has a husband anymore. But linking those problems maybe to the alcohol use might be beneficial. But yeah, in reality, if she wants to continue using alcohol, she's going to be able to do that without us interfering until she lacks decision-making capacity. And, that might involve guardianship. It might involve like a healthcare surrogate. It just gets, bad. So it gets much more complicated after that. But yes, I mean, this is a free country and you are free to make bad choices.
Yeah. Oh, I see. So Nicole, the Lum says, she says, have a good time upon conclusion of our office visit and jokes, let's go get a margarita. Yes, we understand we're heading down a capacity road, but she's not there yet. Thanks. And, Sarah comments, have you asked your client what the alcohol does for her? And I actually want to follow that up with what Dr. Lum was saying about what, linking it up with what matters to her, I think is kind of a key. And I think that's what you were thinking about. How would you approach it, Sarah?
Yes. So it is a cognitive behavioral approach, and so oftentimes when I have asked clients, what is it that the alcohol does for you? A lot of them will say, because I used to see most people in the hospital, and they said, well, it helps me not to feel sad because my wife died 6 months ago. My children don't want to see me. They don't want to talk to me anymore. And that has begun the dialogue and conversation about getting that person help. Sometimes it does work, Dr. Lum, sometimes it doesn't. But unless we start to ask the question, we may never know. Other people have said it helps them sleep better. And they haven't discussed it with their doctor that they have this insomnia because they're having these intrusive thoughts about their memories of the war. So it could be a number of things, but everybody's kind of written them off because they're an alcoholic. Until like Mary says, now they're having liver disease problems and other kinds of issues.
Thank you. Anybody else with some wisdom to share? She says, great recommendations. Thank you. Yeah, in fact, I guess if she wants to go out for a margarita and she's inviting you, it sounds like she's lonely. Maybe she needs to be set up with some kind of socialization scene. Anybody else have cases or questions? So yeah, so I'm gathering. So the questions that you guys brought up for this case, which was really great, is basically your brief intervention. I take that, right? And so that doesn't require referral. Yeah. Anybody else had success using the brief intervention method? I know we have some case managers on here. Anybody want to share any of their stories about diagnosis or detecting and screening and trying to get help for your clients?
Hey, Dr. Nguyen, this is Shane.
Yes.
Yeah, I do case management in the community, and I will say that unfortunately it's the common story, and I think it's been reiterated already here, that it's just a matter of constantly acknowledging if someone's denying that they're using the substance, and acknowledging the fact that they can come back at any time and we will have resources available for them. So it's just providing a consistent, safe messaging that I find does make a difference, but it can be 5 visits, it could be 20 visits, it could never happen. It might occur on the first visit, but letting them know that we do have resources available to help if and when they're ready to address that issue has been really helpful in our work.
Mm. So it sounds like case managers can, and social workers probably can consistently go out and keep on knocking that door and giving reminders to sort of augment what the primary care physician may have concerns about. Is that right?
That is correct. And ideally, yeah, there's a lot of collaboration between community case management and their primary care providers or other specialists. What we find, of course, in the current model is that oftentimes everybody is so busy that we're sending paper back and forth, but nobody's really talking. So ideally, if it is of a significant concern, there's a direct conversation about that. And then, yes, the engagement that the service coordination or case management teams have, I think, is really that point to leverage, especially if they're seeing someone, several times a month or more frequent as needed. Obviously a bit different during the pandemic as we're not doing face-to-face stuff nearly to the capacity we were, but there's still a lot of that telephonic engagement that does play a part and I think has a lot of opportunity.
Great. Any stories from our primary care providers and nurse practitioners out there? What has helped? Okay. I'm going to still leave it open in case you guys have questions or comments, but I'll just point out that evaluations are required for CMEs, and the social work CEs are also available. And so you can click on the link in the chat box and you can complete your evaluation right away for this session, but also you can type in any other topics you would like to see in the future. So please feel free to do that. Okay. All right. Any parting words of wisdom, Dr. Lum?
Nope, just, screen. I think that's the most important thing. It's hard to treat without finding it. So
Yeah. Thank you so much for that reminder. Having realized that, yes, the baby boom generation has now come of age, and we should be expecting to see more, and that we should be more on the alert and more empowered to use our community partners to help as we all look at this together. So thank you very much. Okay, so before we end, I just let me see if I had a comment here for here. Okay. Yeah, so our topic next month will be geriatric approach to nutrition and weight loss in older adults. And so if you have any patients struggling with weight loss or maintaining their weight or not having